Thank you for joining today's webinar. Dr. Douglas Cines will now begin the program.
Good afternoon, and welcome to today's program, a case conversation entitled FcRn, Key to the IgG Universe. I'm Doug Cines. I'm a professor of pathology and laboratory medicine and medicine at the Perelman School of Medicine of the University of Pennsylvania. I'm joined by my colleague, Dr. James Bussel, who's professor emeritus from Weill Cornell Medicine in the departments of pediatrics, medicine, obstetrics, and gynecology. We've been invited to speak with you all today by the Foundation for Women and Girls with Blood Disorders. The FWGBD mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. FWGBD aims to provide education to healthcare professionals on the medical consequences and unique issues for women and girls with blood disorders. Next slide, please. Since its inception, the Foundation has focused on realizing its vision through these objectives that you can see displayed on this slide. Next slide, please. Housekeeping issue: to ensure the best sound quality during our program, all attendees will be muted. However, you'll have the opportunity to participate in a question and answer session at the end of the program. You can submit your questions during or after the presentation portion via the chat box in your control panel on the right-hand side of your screen, and we'll try to address them during the Q&A session at the end of the presentation. Overview: the next few slides detail our accreditation process. In support of improving patient care, this activity has been planned and implemented by Cines and the Foundation for Women and Girls with Blood Disorders. The activity is supported by an education grant from SOBI. Next slide. The learning objectives for this program are the following: 1, review the biology of FcRn. 2, describe the pathophysiology of immunoglobulin G mediated blood disorders as they affect women. And 3, discuss the mechanism and clinical effects of FcRn inhibitors in ITP. Next slide. The following are disclosures on behalf of the speakers and planners for today's activity. Next slide, please. All attendees will receive an email an hour after the program's conclusion with the evaluation and this link to claim your 1 credit hour. The accreditation overview is also available as a handout, and the link will be shared again at the conclusion of this program. Next slide, please. I'm going to hand the slide control over now to Dr. Bussel, who will be giving the talk. Thank you.
Thank you very much, Doug, and thank you, FWGBD, for allowing us to share what we hope would be some interesting information. We put thanks to Rick Blumberg, Sally Ward, and Jester Vederson because they're the people, to the best of my knowledge, who have provided the critical information behind this. The slide didn't advance. Maybe I didn't hit it enough. Oh, there we go. Sorry. Now, of course, I hit it again. Here we go. We have some polling questions to start with. Could we put the first one up? Please tell us how many people are joining you today for this conversation. You can select according to the bottom choices. You're watching by yourself, 1 other person, 2 other people, or 3 or more. Please check off whichever category fits you best. Next slide. Next polling question. FcRn, which is the subject of today's talk, or the neonatal Fc receptor misnomer, has which of the following functions? Protection from catabolism of IgG and albumin, transport across cells of IgG, presentation of antigens for development of immunity, only A and B, catabolism and transport, or all of the above. Please select one of these 5 options. And the last polling question is, the best clinical results thus far of inhibition of FcRn are seen in, and please select one of the following: myasthenia gravis, ITP, pemphigus vulgaris, and then A and B, which would be myasthenia and ITP, or B and C, ITP and pemphigus vulgaris. Okay, we will, if FcRn, last one, if FcRn is inhibited, select one of the following: IgG, IgM, and IgA levels will fall. Option 2, IgG levels will fall. Option 3, IgG and IgM levels will fall. Option 4, IgG levels will fall. Vaccinations will be unsuccessful in generating good antibody responses for 6 to 12 months. And option 5, IgG levels will fall and B cell levels will decrease. Please select one of these 5 options. Thank you very much, Trudy. So we're going to move through the talk. Those polling questions will come back at the end. Would like to review FcRn biology, therapeutics that allow one to have longer retention of antibody or of other molecules in circulation, treatment of autoimmunity, and then briefly at the end, blocking maternal to fetal IgG transmission. What's important about this to me, and the reason I wanted the opportunity to talk about it, is not that this is such a brilliant area for new therapies that ITP or other diseases are going to be completely taken over by treatments in this area. It's more how central FcRn biology is, how unknown it is to most people, and how it impacts many, many things that we are not even usually aware of. I don't know what I'm not doing, Trudy, but it's not changing for me. This is a landmark paper from Bramble, who's given credit for much of the early work, and it focused on the transmission of immunity of IgG from mother to newborns, and secondarily to the catabolism of immunoglobulins. One of my favorite things about this is that he was, at the time, the honorary director of the Agricultural Research Council Unit of Embryology and the Lloyd Roberts Professor of Zoology at the University College of North Wales in Bangor. One of the important things he did that led to his hypothesizing back in the 60s that there was a recycling phenomena for IgG was, and can you see my pointer? Doug, can you see it?
We can.
Oh, great. Sorry, thank you. So the idea is that when IgG levels are very high, the half-life of IgG is relatively short. But then in this stretch, and it looks like a small stretch, but this is from say 2000 to say 500 or less, the half-life of IgG increases enormously. And the point about this is that it appears to be saturable past a certain point. Higher IgG levels don't matter. And on the bottom, the same is true, but that the level of IgG affects its own half-life. The first patients were reported by Tom Waldman at the NIH in 1990, and subsequently, with the help of the laboratory of Clark Anderson, Tom arranged for these patients to be sequenced and identified that the findings in them were related to a deficiency of the neonatal Fc receptor, FcRn, in this case, due to part of it, a mutant beta-2 microglobulin gene. In these two patients, thank you. In these two patients that had first cousin parents, and thus they ended up with a homozygous single amino acid substitution, each of the two siblings, a boy and a girl, very low IgG levels. You may know that normal is typically over 600, and they were 130 and 310. Their albumin levels were very low as well. And back then, they could be studied with radioactive iodine, which demonstrated that there were normal synthetic rates of both the IgG and the albumin, and simultaneously a 5-fold increased catabolism of IgG, defining the role of FcRn in recycling. So FcRn has multiple functions. The first one is IgG transport and antigen retrieval, but primarily transport across cell membranes from the apical to the basolateral. And this is based on charge. This is better described in the second function, which is to protect IgG from catabolism. And I will show you some better features of that. The same thing occurs in protecting albumin from catabolism. And then the growing interest and definition of something that's still not very well understood, which is the role of FcRn in phagocytosis, innate immunity, and in particular to serve an antigen presentation to induce immunity. So when I first learned the simple overview of FcRn as an inhibitor of catabolism, I thought, what a brilliant plan by nature. We have an IgG antibody to an infectious agent. That antibody through other Fc receptors, excuse me, brings the agent to a macrophage. It goes into an acidic phagolysosome. The infectious agent is destroyed, and the specific anti-infectious IgG antibody is recycled so it can go out there and bind to another organism. And I thought that was the best thing I'd ever heard. However, it's not quite as simple as that. And this starts to get into the complexities. The great majority of IgG recycling does not occur with antibodies bound to other either organisms or cells. Rather, plasma is pinocytosed or ingested by endothelial cells and particularly macrophages, and the other plasma proteins are destroyed, and the FcRn rescues the albumin and the IgG specifically so that they still survive. It does this because it binds them only at low pH, and low pH here would mean something like 5.5. So when they're in the acidified endosomes, other proteins get dumped, but FcRn binds and rescues the IgG, and then it transports them and the albumin and transports them to the cell surface. There with neutral pH, the affinity of IgG and albumin to FcRn is very low. And this has to do with critical histidine residues that become protonated at neutral pH at the cell surface, and this protonation disrupts the salt bridges that holds the IgG to the FcRn. Now, this is not only of use as originally conceived of in the name in transferring IgG from the mother to the fetus, or not to the fetus, excuse me, to the newborn, either through the placenta as a fetus, which happens in humans, or through the intestinal lining, which can happen with breast milk, but that's particularly dominant in certain species like mice. But it's also widespread cellular and tissue expression in many different types of cells, and primarily the cells that do not have much FcRn are T cells and NK cells. This is a slide that shows how FcRn has been either demonstrated or suspected to be important in many different tissues. And while it's easy to imagine IgG using FcRn to go into a cell to have an effect, it also may transport IgG at the blood-brain barrier out of the brain and into the circulation, and may thus protect against neuroinflammation. So there's complicated roles here, and transport can go in two directions in certain settings and can be involved virtually anywhere in the body. To also point out one last thing, FcRn itself is a pan-echovirus receptor. So it's pH independent. It can bind, the echovirus can bind to it and use it to enter a cell. There's a lot of work ongoing that, for example, has shown that with Zika and HIV, antibody can then use IgG antibody to a virus, one of those two viruses, can then use FcRn, which in transporting the IgG into the cell will also transfer the virus. And there are other viruses that may take advantage of it as well. So this is an area that's under considerable investigation and for which it's not completely clear yet exactly how it functions for different viruses. This is a picture of it. Here you see the beta-2 microglobulin, and there are 3 alpha helical domains that are thus in total making an HLA molecule. And instead of having a pocket to generate immunity, it has a pocket to transport with. Now, importantly here, if you see FcRn in the middle, where it binds albumin on one side and IgG is totally on the other side. And this is what's been important in allowing us inhibition of FcRn because you could block, for example, IgG binding and not block albumin binding. And albumin levels are important to be monitored in clinical settings with FcRn inhibitors, and we'll come back to that later. It has been shown, as you see in this cartoon, that it takes 2 FcRns to bind 1 IgG, and it binds to the CH2 and CH3 domains of the Fc portion of it and binds across the alpha helix and the beta-2 microglobulin. And then these 2 Fc receptors have motors that have not been fully described yet that would then take it to the cell, the IgG to the cell surface. The best cartoon of this is shown here, where you see the IgG in blue, another serum protein in yellow, and these IgGs enter an acidified endosome, not on an immune basis, but by pinocytosis. The IgG is picked up by the FcRn, which is on the inner membrane of the acidified endosome, and then this bound IgG is transported to the cell surface where the dissociation occurs and the IgG can re-enter circulation. Albumin would function the same, but other proteins that are taken up by pinocytosis would be degraded. And thus, this mechanism ensures that IgG and albumin have among the longest, if not by far the longest, half-lives of proteins in circulation. So, okay, that's very interesting. What about manipulating FcRn to enhance treatment? Well, one option that is going, I think, to become a near universal option for monoclonal IgG antibodies is to mutate the Fc piece of the IgG to increase its affinity to FcRn and thus even more efficiently recycle the monoclonal IgG such that maybe you double or even more its half-life. One of the ones that's been done for this is ravulizumab or Soliris. This is the now long-lived form of eculizumab that can be given much less frequently than you previously had to give eculizumab every 2 or 3 weeks. This could be every several months, 1 to 2 to 3 months. That was also done for other antibodies like Evusheld, which may be remembered as an anti-COVID-19 SARS-CoV-2 antibody. And this could be done with essentially any monoclonal. Another approach, which was actually started earlier, and etanercept was the first molecule in the late 1990s that took advantage of this, is to attach a small molecule to either an IgG Fc piece or to albumin to increase its half-life by getting it recycled. And this was done with a number of the extended half-life factor 8 and factor 9s, and is the way that romoplastin or Nplate and abatacept, an anti-CTLA-4 antibody, currently are in order to increase their half-life. Now, how else has FcRn been exploited? This is the area that's probably better known, and that is to inhibit FcRn. So if you have an IgG-mediated autoimmune disease, or even an IgG-mediated alloimmune disease, if you inhibited FcRn, you could dramatically reduce IgG levels, and that would be all IgG levels, but that would include the autoantibodies. So I'm going to show you data on the ones that have been studied the most, myasthenia gravis and ITP, but recently, especially neurologic diseases have been studied as well. What I will also say here and possibly repeat later is that there are diseases that we think of, oh, this is an IgG disease. So boom, if you inhibit FcRn and reduce IgG or reduce it in some other way, plasmapheresis, et cetera, you should make great improvements in the disease. And part of what's being learned in the inhibition of FcRn is that not all diseases are as IgG mediated as they're thought to be. And it could be that in the ones where it is known to be that, it would be important potentially to use these inhibitors early to have as when there's the maximum IgG effect, maximum in terms of affecting the disease, and minimum effect with other cells involved, for example, T cells. More recently, and this is going to be the subject of another Foundation for Women and Girls Blood Disorders webinar in, I believe, January, and was recently published in the New England Journal in the beginning of August in the first pilot study with proof of principle. An FcRn inhibitor has been explored to prevent transmission of maternal IgG to the fetus and thus prevent occurrence of fetal disease mediated by those antibodies. This is a list from a while ago of some of the trials that are in progress. I'm going to highlight one in particular, I think, with efgartigimod, which was the first one licensed, and it was licensed in myasthenia gravis in late 2021, I believe. There are a number of other inhibitors, as you can see. Efgartigimod is unique because it is only an Fc piece with 5 amino acids modified to increase its affinity to FcRn. Nipocalimab and rozanolixizumab, which are the other ones that have been used the most, are so-called effectorless IgG molecules. Rozanolixizumab because it's an IgG4, nipocalimab's an IgG1 that has been deglycosylated. And there are others being tested as well. Currently, efgartigimod and rozanolixizumab are licensed for myasthenia, and efgartigimod is also licensed for chronic inflammatory demyelinating polyneuropathy. Oh, sorry, I thought this was, and just this bullet points out that it is licensed for people who have known anti-acetylcholinesterase receptor antibodies, which in myasthenia is the great majority of the patients. This is the first of 2 slides I want to show you on myasthenia to illustrate a couple of points. If you look at the yellow and the red and the yellow, red is all IgG, and yellow is the specific IgG anti-acetylcholinesterase antibody. And what you see here in these patients with myasthenia is that those antibodies decrease together. The IgG levels are going down over time as the FcRn inhibition has happened, there's a reduction in catabolism, so the IgG levels fall dramatically. And then as the effect wears off, they go back to normal. But the interesting thing is that these are happening almost in perfect parallel. Now, the blue and the green levels are scores. The blue is the myasthenia gravis activities of daily living score, and the green is the quality of life in myasthenia gravis. And you see that those go down and come up in parallel to the IgG and IgG anti-acetylcholinesterase. And in that setting where the scores go down, that means less disease activity. Now, obviously, how perfectly the numbers superimpose is a bit of an accident because they're not all the same percents, et cetera. But you can see how the effect of inhibiting FcRn, increasing catabolism of IgG, can have a nice effect on not just the primary pathophysiologic mechanism, but also on the disease activity in the patient. And I should say here that we do not in any way know yet whether this will be in any way a lasting effect with continued treatments, and we can come back to that later. This is looking at another myasthenia study that led to the licensure of rozanolixizumab. And you see here something very similar. This is a completely different set of data from a different study. The red and the yellow, the specific IgG to the acetylcholinesterase receptor and the overall level of IgG are almost in parallel. And the two scales are not quite as much in parallel, but both go down, showing less disease activity as the antibodies go down and come back up as the antibody levels increase. Now, I think one of the points I'm going to be making is that's not always so clear for other entities, which may be why, for example, there are no FcRn inhibitors licensed in, for example, ITP. And I'm going to show you the best acute results of anti-FcRn therapy in ITP from the phase 2 rozanolixizumab study. And the point here is, and you can see that there are different doses. Focus on the purple and the purple one, which is the single highest dose in that study, 20 milligrams per kilogram. And what you see here is that in 3 days, the mean platelet count in the 10 people getting it, as opposed to those getting placebo, have a mean increase in their platelet count in 3 days of 60,000, even though at a week it keeps going up and is much higher. Now, why is this immediate response relevant? And by the way, you see a lesser immediate response at the next lower dose of 15. And I'm hoping that there we go. You see here that we're looking at the IgG levels falling, not antiplatelet IgG, just IgG. And what you see is that when the platelet count has gone up dramatically by 60,000 from 20 to 80, in that same window, the IgG level has only dropped from 1,000 to about 600. So it seems a little unlikely that the total effect, I would say to me, it's very unlikely that the total effect of this dramatic increase is seen by reducing the IgG level by only 40%. But since we don't have great measures, as I suspect callers know, of IgG levels, it's not certain exactly how that was affected. And the responses, as you can see here from the dots, are early, and even at lower doses, the responses are either at 4 days or within a week. So that's a good thing in that I might have expected it would take 2 or 3 weeks to see a response. Now, I show this slide because the main possibility in my mind for the rapidity of the response is that the binding of the anti-FcRn IgG in the rozanolixizumab has somehow inhibited phagocytosis above and beyond lowering the antiplatelet antibody levels. This is taken from the best study in 2006 from the Dutch Red Cross and Jester Vederson. And you see here that in the wild type animal, the beta-2 microglobulin deficient mouse and the FcRn deficient mouse, the antibody binds to the bacteria in all those settings. But when you look to see ingestion in the wild type, the bacteria is completely ingested. But in the beta-2 microglobulin deficient and the FcRn deficient model, there is not complete phagocytosis by any means. So this suggests that there is an effect on phagocytosis, and this remains to be better described, but may explain some of the results we see. Now, going to the best article overall in ITP, we see here that this is the phase 3 study of the use of efgartigimod, the Fc fragment, in ITP. I'm going to show you a lot of slides from this. It was randomized 2-to-1 to give the active agent, the efgartigimod, to patients as opposed to giving a placebo. And there were 80-some people getting efgartigimod and 40-some getting placebo. And this was the primary study objective, which was to have 6 out of 8 of the platelet counts greater than 50,000, 4 out of 6 of the platelet counts greater than 50,000 at the end of the study, so in weeks 19 to 24. And this was significant, and you can see that the primary response here was 22% in the efgartigimod group and 5% in placebo. And this could be blamed on the fact that this was in general a very refractory group of patients, so other disease mechanisms might have had time to creep in. I'm going to try to run through some of the other data now. The blue line, as you can see, the platelets, and this is platelet increase, so from less than 30 increasing in general by 20 to 40. The IgG, as is typical in almost all the trials, is decreased by 60% or a little more. And in the secondary endpoints, the International Working Group platelet count response was achieved by 51% in the 86 on efgartigimod compared to 9 or 20% in those on placebo. You also see the blue efgartigimod on the left is the number of weeks of control, and you see how much more that was in the efgartigimod group, with 45% and 44% having 4 to 10 weeks of counts over 50. And this shows that in all the different subgroups, when you break it down, while it wasn't significant, they all did better. Essentially, all the subgroups, as you can see by the dots, with efgartigimod. Importantly, there were no major safety findings that occurred, and most safety findings have either been headache with infusion, and this study was done with the efgartigimod being given IV. But it was well tolerated, and there were no findings of hypoalbuminemia, which in other studies has been shown that it can occur. And if it does, you'll also get hypercholesterolemia, and it may change the half-life of drugs that bind albumin in the circulation. Importantly, in this, as you see in yellow, and all the other studies that have been carried out, there has not been a finding of a higher incidence of infections, despite the IgG levels reaching levels that would normally, if they were a common variable immunodeficiency patient, get substitution with IVIG or sub-Q IG 4 weekly to prevent infections. This is, we believe, because you do not inhibit antibody production at all. So the specific antibodies that are there are good, the IgG ones. The IgA and IgM are unaffected. And that is thought to be the reason why infections have not been a problem in any of the trials with these agents. There was a subsequent presentation at ASH last year with the same data from the efgartigimod phase 3 ITP study. And the point here is that with the efgartigimod in green and placebo in purple, looking at weeks 6, 12, 18, and 24, as you can see in the yellows, things either happen better or especially more quickly on the efgartigimod arm. And for example, there was faster time to 2 platelets greater than 30, count greater than 50, 2 counts greater than 50, greater than 100, etc. Again, emphasizing the efficacy of the treatment. Huge but. So, hey, so why wasn't this licensed for ITP? That was a phase 3 study. It was followed up by a subcutaneous study, and it was believed that the subcutaneous study would be just as good. And this was going to be a registrational trial. The patients were similar to the ones in the IV phase 3 trial that I showed you. This has not been published yet. And there were 207 patients randomized again 2 to 1. 3/4 of the patients had received 3 or more prior therapies, so maybe a slightly more refractory. And the bottom line was the placebo response rate was higher than the efgartigimod response rate. Now you could say, well, gee, the placebo response rate was a fluke. Why would they respond to such a high level? But the primary response rate on efgartigimod was substantially lower. It went from 22% to 14%. In addition, none of the secondary endpoints of the types I showed you before were met. Now, there are many possibilities as to why that could have happened. I wondered, is it the route? Because with IVIG, it's been thought that maybe you need to get to a peak count, and you know that the peak level matters. It's not just the area under the curve. So I looked for data on whether you could switch from IV to sub-Q in patients with common variable immunodeficiency and what happened to their ITP. since you may know they have a relatively high rate of ITP and of autoimmune hemolytic anemia. Bottom line, there is no data in which patients, for example, with CVID and ITP, get sub-Q IgG to bring up their platelet counts. Essentially, everybody would give IVIG, not sub-Q IG, if they were trying to fix the platelet counts. Whether that's actually correct or not, I don't know. But if phagocytosis is involved or other things that require a higher peak level, that may explain what was going on. Now, I just want to finish for 1 minute on looking at hemolytic disease of the fetus and newborn, HDFN or RH disease, and this is going to be very brief. It has been thought for a very long time that to get IgG across the placenta, you need FcRn, and that's why, in general, when you compare maternal to newborn IgG levels, the newborn is slightly higher, like 105 to 110% of maternal levels on average, and this has been explained, again, a hypothesis, that it's because of active transport across. Now, if you look at this cartoon and you see the mother circulation on the top, the first layer of cells are syncytial trophoblasts. They express FcRn, and it appears that to go from the circulation into the interstitial connective tissue, you need FcRn. However, going from this tissue into the fetal circulation, it's not clear whether that's entirely FcRn, partially FcRn, or not FcRn at all, because there are other Fc receptors. I'm going to show you a slide of data just to first show you the study, but then talk about the idea of other means of transport. These are the 13 previous siblings of the patients reported in treatment who are in blue. What you see where there are 8 black X's is that these pregnancies ended in fetal loss, usually before 25 weeks of gestation. You see that the ones that survived had many red diamonds, which is standard of care in utero transfusions with red cells. And some of them, like here, this one got IVIG as well. If we look in contrast to the ones that from week 16 to week 35 received increasing doses of the nipocalimab inhibitor of FcRn, you can see that there are 1, 2, 3, 4, 5, 6, 7 that did not require any in utero transfusions. And of those 7, only 1 even required a postnatal transfusion. However, we need to learn why some did extremely well and some had their start of their transfusions delayed, but still required them. And this is something that will be explored and is being explored in ongoing studies. Now, just to finish, there's a study that purports to show that there's the role of a second Fc binding receptor in non-human primates, and this is in macaques. And this study was not done to show that. This study looked at an HIV monoclonal antibody, these recombinant antibodies, and wanted to compare those derived from mammalian tissue culture to those that were plant-derived in order to make it easier to make these antibodies. And what you can see here is that binding to FcRn for the plant monoclonal in green or the mammalian in blue, binding to FcRn was about the same. There was no difference in affinity to FcRn, and for example, no difference in affinity to Fc gamma R1. But you can see that the plant antibodies did not bind FcR2a or FcR2b or FcR3a very well at all. And that may explain why they did not achieve, in the macaques, why they did not achieve transplacental transport. So this is another suggestion that this is important. So last slide, just showing you again the functions of FcRn, cell transport of IgG, protection of it and albumin from catabolism, and the burgeoning area of its role in antigen presentation and immunity. Thank you for giving me the opportunity to talk about this area. And I guess, Trudy, we're going to do the polling questions again. So which of the following functions does FcRn have? Protection from catabolism of IgG and albumin, transport of IgG across cells, presentation of antigens for development of immunity, only protection from catabolism and cell transport, or all of the above? Please select one. And we can see that everybody answered only protection from catabolism and transport across cells, but FcRn also contributes to antigen presentation by taking antigens attached to IgG and delivering those to in dendritic cells so that they can present antigen that way. So they have this additional function as well, although it's not fully understood. Next. Best results of inhibition of FcRn are seen in myasthenia, in ITP, in pemphigus vulgaris, in myasthenia and ITP, or in ITP and pemphigus vulgaris. Please select one. And people said myasthenia and ITP, which is correct. The only point is there's intermediate or different level results in many areas, but pemphigus, the studies did not work out. And the next polling question, last one, I believe. If FcRn is inhibited, which of the following occurs? IgG, IgM, and IgA levels will fall. IgG levels will fall. IgG and IgM levels will fall. IgG levels will fall and vaccinations will be unsuccessful for 6 to 12 months. And IgG levels will fall and B cell levels will decrease. So this is partly my fault because I did not specify that the limited current data suggests that vaccinations are perfectly possible, although to be prudent, one would separate IgG separate FcRn inhibition from vaccinations. But the point is the other immunoglobulin levels don't fall and B cells don't change. Thank you very much. And we're open for questions. Doug, can I ask you, while we're waiting for questions to appear, could I ask you why you think that the ITP results, even in the phase 3 IV trial that had statistically significant results, why those results are relatively unimpressive when we think that ITP is predominantly an IgG-mediated disease?
Well, there's a lot of reasons. I mean, one reason is the high affinity antibodies are on the platelets, and that FcRn doesn't deal with immune complexes like antibody-coated platelets the same way as it deals with soluble IgG. There's also issues related to complement activation and non-immune activation that can lead to non-IgG mediated clearance. There's T cell involvement perhaps, and so it's not clear that. And there's also inhibition of the megakaryocyte production of platelets. So the pathophysiology, I think, is just more complex than it is in myasthenia, where I think the antibody getting onto the receptor is the pathogenic process.
Yeah, I think that it may be that it will be more confusing also in other presumed IgG-mediated diseases. Like, I would have thought that pemphigus would be something that would, but I don't really know anything about pemphigus, so I can't comment on it. And I wonder also if that means if you're going to use FcRn inhibiting agents, that those should be used early in the disease process, that maybe they would be better in newly diagnosed ITP than an ITP that's relatively refractory.
Well, the trials have been done in refractory patients, and they're presumably the ones that have a lot of things going on, for sure.
And one other thing that I find fascinating, and I know we're coming to the end of the hour, I find fascinating trying to figure out how much of the IVIG effect in ITP is due to saturating FcRn and in effect being an FcRn inhibitor, especially at 2 grams per kilo. And the data in that phase 2 study, the platelet increases looked like what you would see with that, with IVIG. And way back, first we thought it was, clogging up the well-known IgG-Fc receptors, but it became clear that it wasn't any single one of those. And then I think the Jeff Ravage data about the induction of the inhibitory Fc receptor, Fc gamma R2b, but clinical trials trying to develop agents for that have not really panned out to the best of my knowledge. So I don't know what you think about how much of IVIG's effect is FcRn mediated.
Don't know the answer. Clearly some, but maybe not. But I doubt all. I mean, IVIG has an awful lot of antibodies and other molecules in it, so I think it's a much more complicated agent than one of these abdex or monoclonals.
Sure. Well,
I think we have to wrap it up now. I think we're at the end of the session.
right. I think PDSA has been very supportive and works closely with FWGBD, and they have a mission to enhance the lives of people with ITP, and ITP is particularly predominant in women of childbearing age among younger adults. So it's been a great thing, and it's good that it works together.
So thank you for all of you for listening and participating, and I hope it was informative and enjoyable. So thank you and have a good day.